some kind of delirium associated
Okay,
with
but
it.
the first thing you're going to do is what?
Break it down by the patient.
Prevalences in place. Don't skip your big prevalences, right? So when we go to our patient, here's my age. Don't tell me the age. Tell me what you interpret from the age.
Elderly male.
Degenerative malignant, right? I don't want to hear that they're 65. I want to hear old enough that my prevalences are going into the degenerative malignant diseases. When you say gender, got it, male repro plus 1 athero. What are you going to put for time frame?
Acute.
Well, it depends on the organ, doesn't it? Right? Because if you're doing, what is the definition of acute for heart lung?
Probably like a couple of days.
No, it's defined. It's 1 week.
Oh, okay.
Oh, do we need to review this? Okay, I guess we better review this.
I spoke too soon.
Okay, chronic for liver is more than?
6 months.
Everyone help him out here. More than 6 months.
6 months.
Kidney?
3 months.
Nice. Joints?
6 weeks.
Nice. Samir, dude, you are really got this nailed. Okay, smarty pants. Diarrhea.
4 weeks.
Oh, and why? Oh, that's so good. And why do I care?
You want to see if it's a workup for infectious etiology versus.
Yeah. After 4, you include everything that's non-infectious, don't you? So that's a nice one. And then heart lung, we sort of think of as 1. So the answer is, I'm just going to note that it's a few weeks, and I'm going to wait to see what my organ system turns out to be. So I got to kind of hold that till I know it. Okay, the next thing you want to do is a chief complaint, and this is where you're going to get punished for not being here yesterday. So, Alex, you nailed this yesterday. What do you want to call this?
Altered mental status.
Okay, so I was taught this algorithm by a neurologist. It's worked great all my life, and so I offer it to you for your consideration. You're going to go to primary and secondary. So remember, primary means that it's intracranial. And if you're in America, that means it's going to be CT scan and MRI, because we know there's rare things. Thank you for that, Alex. So, but nonetheless, imaging will rule out significant primary disease. So that's a really nice testing teaches pathophys. That works really well there. But when I say secondary, who can tell me from yesterday what we're going to do for secondary? You lazy dogs, Dino. Okay. So when I say Dino, what are we talking here? D for?
Drugs.
So get your urine screen. One of the E's?
Electrolytes.
Nice. What are my 2?
Sodium, calcium.
Nice. Next one?
Endocrine.
Nice. What are my 2 hormones that make you mentally change?
T4 and cortisol.
Excellent. N for?
Nutrition.
Okay. And what are my 2 vitamins?
Thiamine and B12.
Sweet. And then every organ failure. Is there any organ failure that doesn't give you mental changes? Not that I know, right? So you've got to be able to do all of the organ failures, which in itself is a really fun lecture, by the way. Okay. But now all of a sudden time frame matters, Richard, because what I want you to break it into is, and what can't you afford to miss, because it's talking about changes in minutes. So what can't you afford to miss right now in America? So all that differential is great, but right now, what are you adding in? Glucose.
Opioids.
Okay, so glucose is one of them. Next one?
Opioids.
Opioids. Next one? Your relaxants. And the third one?
B1.
What's that?
Thiamine again.
Okay. So one of the things they talk about when you get out into the ERs is they talk about the coma cocktail. No one can actually show from a study that it saves lives, but it's a really nice way of thinking about your differential, isn't it? Okay. So when I say mental changes, you're going to think Dino. And then if you're in an ER situation, the coma cocktail. So that's why acute kind of looks different here, doesn't it? Because acute kind of has a little thing to it that says right now. Okay? Okay, so knowing this, the reason this is so useful is it tells you what you're going to order next, isn't it? Now, all of a sudden, when you look at this person, if the physical exam isn't going to help you, well, you got to go fishing and you got to explain those. So you know for sure you're going to get your CBC, your urinalysis, and your chem. For sure, that's going to be what you're going to start with. And then you can see you're going to add a urine screen for drugs. You're going to look for a T4 and maybe a cortisol. I mean, that's pretty uncommon, but you would be thinking about it, right? What would be the commonest situation? I would look for an acute cortisol insufficiency.
Hypotension.
Different ages. 2 different ages. 2-year-old, meningococcus. Right? That's what our Waterhouse-Friedrichsen is. So just think who that is. When I say meningococcus, walk me through the presentation and natural history of that. Go. How's meningococcus going to present? Oh dear, do we need to stop and talk about meningococcus?
Fever.
Apparently we do.
Fever.
Good. Okay, fever and what? Okay, so when I say meningococcus, let's just take a little break here, shall we? This was not an acceptable performance. So when I say Neisseria meningitidis, okay, natural reservoir,
Esophagus.
humans, right? You get it from, you get colonizing nose, okay? And then symptoms. So when I say meningococcus, look what I'm going to write. Meningococcemia. Because there's actually 2 different patterns of disease that overlap each other a lot. So you think of them as both together. They are, look at its name. The name's a big clue. It's going to be, right, so it's meningitis. When I say meningitis, what are the symptoms? You got one of them, Samir. Fever and?
Rigidity.
Buccal rigidity.
Fever, headache. No one walked in and said, boy, my neck is really friggin' stiff. Don't confuse symptoms with signs. Symptom is what the patient complains of. Sign is what you look for. So the symptoms of all CNS infections are headache and fever. The differential diagnosis of CNS infections is meningitis and encephalitis. How do we differentiate them?
Altered mental status.
Well, they both can do that, actually. But although that's fine, you're absolutely right. There's more mental status changes in encephalitis, so that's fine. What's the name? Meningitis. What are the 3 things that cause pain? Inflammation, ischemia, and something with the word nerve in it. Okay? So if I have meningitis, does it hurt? Yes. So any test that stretches the meninges will elicit pain if it's meningitis. So what are the 2 ways we stretch the meninges? Yep. So that's my nuchal rigidity. So that's it's appropriate to bring it in. Just don't confuse a sign with a symptom. And
Flexing the knees.
yeah, the straight leg test, right? So that's going to stretch it from the backside. So those are the 2 ways, but they're just stretching meninges. There's nothing magic about that. Okay, so meningitis, you're going to see classically it's a little kid who's going to come in and have headache and fever with on physical exam meningococcal, and then you'll do a spinal tap. And what will you find in the cerebral spinal fluid?
White cells.
What kind?
Leukocytes. Or
Yeah,
neutrophils, excuse me.
Leuco is Latin for white.
Neutrophils.
Cyte is for cell, so that's redundant.
Well, as opposed to lymphocytes, but neutrophils.
Neutrophils. Because what's the signal, Alex?
Pam.
Yeah. So you know it's got to be a neutrophil, right? Okay, very nice. Okay, so neutrophils. Glucose is low.
Glucose.
Glucose is low. Protein is
High.
high. And the organism is a
Diplococcus.
gram-negative Diplococcus. Okay? Good. So that's just part of how you're going to see your life. So meningitis is part of it. But look what I've written here. Coccemia. So what does that tell you?
Infections in the blood.
Yeah, right. So you know that it's going to be as well as sepsis. But here's what's unique about this organism. Tell me about its capsule. What does that mean, LOS? The capsule is different than your normal capsule. It's a lipo-oligosaccharide. So it's really small and it sheds. And so it acts as a toxin. So between the organism and the shedding capsule, you get a vasculitis. So when you talk about how often is this, it's about 70% meningitis, about 10 to 15% pure vasculitis, and then in the middle, they overlap a lot. Okay, so why do I care about the vasculitis?
Yeah. Clotting.
Yeah, because they go into a vasculitis and they go into vasomotor collapse and you get Waterhouse-Friderichsen. So how are you going to recognize that vasculitis? Right? I mean, here's your little kid. You get a friggin' little kid. You've got that friggin' headache with meningitis. You get that tap. You're not waiting for the lab to call you. You're probably going to go down and look for it because this matters. And the second you see the gram-negative Diplococcus, what are you going to do about that friggin' vasculitis dead from Waterhouse-Friderichsen? What are you going to do about that? How do you recognize it? Palpable purpura. Okay, so what's the difference between palpable petechiae and non-palpable petechiae?
The palpable ones are from vascular damage, and the non-palpable ones are just from platelets.
Excellent. That's exactly right. So every time you say petechiae purpura, you're always going to say palpable, non-palpable. Non-palpable, you're just leaking blood because you got low or non-functioning platelets. Why are they palpable? Because vasculitis, rubor, tumor, Cowler Doler. We're back to that friggin' exudate again, right? Everything drives off that exudate, doesn't it? So when you talk about that little kid, what's the next thing you're going to do when you have gram-negative Diplococci? You're going to look over all of that skin. And if you find palpable petechiae after you faint, what are you going to do next? How now are you going to go looking for Waterhouse-Friderichsen? How are you going to look for that? Come on, Alex, you can do this because we talked about it yesterday. When I say cortisol, what do you say? Blood pressure, right? So when I say you're following that friggin' little kid, boy, no kidding, man. The second you see a whiff on that, in goes the cortisol before you ever do the CT to see the adrenal bleed. So this was one of the last things that happened to me when I was in practice. So this must have been, I don't know, 2008-ish. We were in a community hospital, North Shore of Massachusetts, and I was looking at tumors with my extraordinarily good hem-onc. And all of a sudden there was a code in the ER, and my office is right by the ER. So my hem-onc goes bombing to the ER. And he came back an hour later. I've truly never seen anyone that angry. I mean, he was genuinely angry. And he said to me, I said, geez, Paul, what? He said to me, this was an 18-year-old girl. She came into our hospital 4 hours ago, and we had the antigen test for meningococcus positive, and she just died. So when I say meningococcus, my heart skips a little beat. My palms get all sweaty. You know, I start thinking about meningococcemia. I think about meningitis vasculitis. I think about this goddamn capsule that's shedding and shedding and shedding. So even if you form antibodies to it, it binds and sheds them off. It's a devil. And you get that vasomotor collapse, and that's tiger country. So my feeling would be, and you can tell me, but you know, I don't think I saw 5 or 6 of them in my life. So I would argue you should look around and say, who's got the most experience with this? And so that's probably going to be whichever hospital deals with all the poor kids in town. So if I was out in my community hospital, they should have called a chopper and sent her down to Boston Sick Kids, because they probably see a meningitis every 2 or 3 weeks. They're going to be way better at it than you. Because, boy, this is heart-stopping stuff. When you see meningococcus, you just have this whole sense built into you. Everyone happy with that? Good story, huh? And just changes how you think about this bug. It suddenly becomes more important, doesn't it? Okay, but we're back now to our lab testing. Okay, so in our lab testing then, obviously, you're going to do show me those. That's really obvious. And then you go through, and that brought us to cortisol. That's where we got distracted. Okay, there you go.
So you have concentrated urine,
Nice.
but low sodium. So
Nice. Okay, tell me about that specific gravity, Alex.
it's saying that the urine's concentrated. So you're
So tell me about the units of specific gravity. How do the units work? How did you know it was concentrated?
I just know that's what it means. low 0.001 is
Why is that the reference range?
I'm not sure. I think
Because that's
you spin down the
That's serum. Every time you're doing osmolality, anything even like it, what's your reference range?
Yeah.
Right? So that's easy. What's water?
Probably the lower end.
So it's centered on water. Water's 1. Okay? And the human can't concentrate beyond 1.03. So if they're beyond that, then you know they've had an IV contrast or something artificial. Okay? So in here, then, it doesn't tell you the patient's dehydrated. It only tells you they're conserving water. But that's the first thing you look at in every urinalysis, right? Why?
It's quick and easy.
No, because it tells you how to read all of these guys. Because these are all concentrations. So a 1+ protein in a concentrated urine, if it was dilute, it wouldn't even be positive. But a 1+ protein in a dilute urine, that's a lot of protein. So every time you start your analysis, you always start with how concentrated it is, right? Because remember, they're all per 24 hours. So if you're allowed, for example, protein's the one you really care about the most. Normal protein has got to be less than 150 milligrams per day. Well, how are you supposed to compare that when you do milligrams per liter? What the hell, right? Kind of depends how many liters you're diluting it in. So you always start your analysis with your specific gravity. Everyone happy with that? Okay, so this is concentrated urine, and now we're dealing with this. So have we got a chief complaint? We got a chief complaint? Absolutely, right? Chief complaint is anything from which you can do a differential diagnosis. So when I say decreased sodium, now you get to say, what is the differential diagnosis? All right. First of all, let's just deal with the pseudos. Okay, so what's a pseudo hyponatremia?
Hyperglycemia.
Yeah, right. So that's just with our glucose, right? And when does glucose start to really affect it?
Greater than 200.
Yeah, why?
Exceeds the threshold.
Osmolality equals?
2 times sodium, glucose divided by 18, UN divided by 2.8.
Right? And we talk about it being abnormal when it varies by more than 10. So 18 into 200, there's your 10. Right? So it actually kind of makes sense. Okay, so those are my pseudos. And then how do we think about it after that?
Volume status.
Nice. Okay. So now when we say increased volume, what do we mean by that?
Increased sodium.
CHF, cirrhosis, nephrotic.
Right. What we're talking about is, remember we did the whole body water discussion and we divided it into intracellular, extracellular, interstitial, intravascular, venous, arterial. And so we said, what defines the intracellular group? That was potassium. What defines the extracellular group? That was sodium. And what defines the vascular group? And that was our albumin. Right? So when we're talking about volume here, we're talking about a reabsorption of sodium here. So that's going to be driven, every time you say sodium and volume, you're talking about your Starling's forces. So you're looking at your two diseases with your increased pressure and your two diseases with a decrease in oncotic. So those volume diseases are going to be cirrhosis. There's my 1 albumin. Nephrotic. There's my 2nd albumin. And congestive heart failure. There's my 1st volume. And that's going to be divided into, and that plus renal failure. So when we say volume, we don't mean water. We mean the sodium compartment. Okay, good. And then when we say decreased volume, what are we talking about here?
Vomiting, diarrhea.
Yeah, right. So this is just what you think, right? So this is my nausea, vomiting, and my diarrhea people. So when I say U volume, I'm talking about
SIADH.
okay. So let's come back now and look at our patient. So which one is our patient? Does it say he has liver disease? Nope. And there's no stigmata of cirrhosis, right? So what would the stigmata of cirrhosis be? What would you be looking for in cirrhosis on the physical exam?
Spider angiomas, pulmonary erythema, ascites.
Okay, I like that a lot. That's a good list. When I say cirrhosis, I always break it into two big pathophysiologic groups. Okay, and if we get to liver, we'll certainly go through this. The first group you're going to see is portal hypertension. And there's 3 findings from that. And the second is going to be abnormal handling of estrogen. So they're a hyperestrogen state. And there's 3 findings from that. So when I say portal hypertension, right, there's your anastomoses. And so there's going to be 3 anastomoses you got to know. They are
Esophageal.
varices, good. The Greek mythology had snakes for hair.
Caput medusa.
Caput medusa. And then where the superior rectal joins the inferior rectal. Hemorrhoids. Okay. Ascites. And splenomegaly. Okay. How do you identify big spleens? I mean, it's cheap talk to say it, but how do you find it? Alex, come on. I'm counting on you, man.
Never found it.
Right. Because palpation sucks, man. Palpation's got to be the dumbest ass thing I've ever heard in my life. I never felt a spleen, and I tried everything. So first of all, and everyone's fat now, so good luck with going through that much to feel. It's hopeless. The other problem you get is you get little skinny young adults. You know how often you can feel a normal spleen? About 2 to 4% of the time. So it's neither sensitive nor specific. So what are you going to do, Alex?
Ultrasound.
Yay! And what's the cutoff for spleen? 14. If it's more than 14, it's splenomegaly. That's just one of those, man, everything should be ultrasound. I'm in love with ultrasound. I think everybody should be good at it. But just doing it around the abdomen, 14 is a good number, huh? Hell of a lot better than, what do you think, Bob? Don't know. Got no clue. When we talk about estrogen, obviously this is going to be feminization of males. And there's your palmar erythema and your spiders. Okay? So they would have to include that. A fair question would have to include that. Okay, what are you looking for in congestive heart failure? Left, right.
Yeah, PND.
Right, left, right. Okay. What are you looking for in nephrotic?
Protein in the urine.
Right? Yeah, there's no physical test for that. And what are you going to do for renal failure?
Creatinine.
Creatinine, right? So you can do that list really pretty fast if I give you UA and chemistry. You can rule out 2 of them, and then the others have pretty straightforward histories, shortness of breath, edema, and the physical exam versus cirrhosis, glug, and viruses, and the physical exam. Happy with that? Okay. So what are you going to bet in this guy with that history then? What's your single best bet for this guy? No history of diarrhea, vomiting. It's too long for it anyway, several weeks. We've got no reason to believe that it's any of these because the physical exam's negative. We can rule out the others. So what are you betting?
SIADH.
Okay. So when you take a look at how we do hyponatremias, there's your nice discussion. Does that feel good to everyone? Everyone happy with that? Okay. So what would you do next? Now that you've got your SIADH, million causes of it, but you're going to divide them into 2 commonest that you're going to see. What are the 2 commonest causes that you're going to see for SIADH?
Small cell.
Right? So you're going to see a chronic low grade, and the model of that is going to be small cell carcinoma. Okay? And who gets that?
Smokers.
And so what are you going to do? If you can't palpate it or see it, you image it. Okay? That's just what we can do now, right? If you can't see it, feel it, then you image it. Okay? So here's my chest x-ray. We haven't done lung yet, so that's a little unfair. Where am I going to see it?
In the center-ish?
Right. These are central. That's a nice answer, right? So these are central because that's why they're called bronchogenic carcinomas, because that's where the highest exposure to cigarette smoke carcinogens is, isn't it? If it was out here, what would that make you think? Non-smoker, so it would be?
Adenocarcinoma.
Right. It works really badly in practice, but the theory is great, okay? Okay, so we're going to go do an image for him and find his small cell, right? And then we're going to do the acute post-op. Okay, so when you talk about these chronic low grades, these people manifest as their low sodium, and so they get mental changes. That is by far and away the commonest presentation. But when you do it post-op, it's a wham bam. These people actually present with oliguria. So now you can see, have we done kidney together, you and I? No? Okay. So now, if we had done kidney, you'd recognize now we've added a second family of diseases into post-op oliguria. The first family is going to be SIADH. And the second family is going to be our pre-renal ATN obstruction family. Okay? So how are we going to know which family we're in? Right? So when you're on surgery and you're dealing with your post-op oligurias, the first thing you're going to look at is your serum sodium, because that's going to divide your 2 families. SIADH is hyponatremia. If it's normal sodium, you're in your kidney-centered damaging discussions. Everyone good? Okay. Happy? No questions? You know what? We're pretty far on. I'm going to do a treat for you instead. We'll come back to this one tomorrow. Let's do this one today because this is nice and tight for our time left. This is a gorgeous one, really fun to do.
So patient's a young female. Still,
And that means
it's still in the range of possibly congenital problems or some developmental problems.
not possibly, dude. Great age for it to show up. Nothing wrong. Under 25 is fine. Anything under 25, you're in that discussion. Okay, good.
But I
Gender?
think also probably in the range of that we couldn't rule out an autoimmune problem as well.
Yeah, I think that's fair, right? She's bumping into middle age. I mean, not advanced middle age like 42, but I mean, certainly sort of a fully formed female. So I think that's perfectly fine. I think that's a good point. Gender, okay, so now we can add in female autoimmune. We're just going to keep that in our mind. I think that's perfectly sensible. And what's our time frame? Well, it doesn't give it, but you'd sure like to know, wouldn't you? Because if it popped up over a day or two, really different feeling than if it's been growing slowly over a couple of months. Okay, so can you form your chief complaint? What family of chief complaints are we in?
ET mass?
Right? One of the standards, neck mass. Okay, so when I say neck mass, how do you think about neck masses? Right? Thyroid, non-thyroid. Right? Absolutely your big group. And how do we differentiate them? Swallow test. If you had come to the Anna Jakes Hospital in Newburyport, Massachusetts, any Thursday morning between 1986 and 2012, you would have seen me walking down the corridor with my Dixie cups and a liter of water. You could have said, he's got thyroid clinic, because I did. Because I did nuclear medicine and we scanned all the nodules in those days because there wasn't really great ultrasound. How did you know that me walking with my Dixie cups and my little bottle of water, how did you know? Because clearly I was going to be doing swallow tests all morning. So if you want to understand the swallow test, you need a picture. And this is the picture you got to have, which, believe it or not, is the anatomy and embryology of the thyroid. So let's just do that. So let's draw a person here. And we're going to draw here the tongue. Now, when you say tongue, you should be thinking about, when I say tongue, how do you think about the tongue?
Two parts.
I always do this. Is that how you guys do it? Right? So it's the anterior 2/3, posterior 1/3, and you can tell because it's got the circumvallate papilla. And so here's my anterior and there's my posterior. This is a very special spot right here. That spot right there where they join, right here, is called the foramen cecum. And that's where your thyroid gland forms embryologically. So what happens to it? Well, it's got to come down. There's my Adam's apple. It's got to come down, and you've got 3 bones here. 1, 2, 3. And so the thyroid knows where to go because it follows a duct that's built for it. So that's going to be my thyroglossal duct. And it migrates down it, and then you get your thyroid gland here. And then this is supposed to involute. But you're left with all these little strings and bits of residual connective tissue. So what it means is anything related to the thyroid or the thyroglossal duct is attached to the tongue. Now, if you haven't thought about how you swallow, you can feel it in yourself. And, if you've got a little sip of coffee, this is a great time to try it. Take a sip and swallow it. And what you'll see is your tongue moves up to the front of the palate and rolls it backwards. It rolls it backwards and presents it to the oropharynx. And then you're ready for the second phase, which is voluntary swallowing. So the tongue moves up and then rolls, which means anytime you swallow, this guy goes up. So anything related to the thyroid or thyroglossal duct goes up under your fingers. So you stand behind your patient for any neck mass, you do your swallow test, and it's thyroid, non-thyroid. If it goes up under your fingers, it's being pulled by the tongue, you got it. Okay? So a couple of things to note. So there's our story, there's our thing. Let's do some diseases here. So the first thing you can have right here is the thyroid doesn't migrate. So that's going to be a lingual thyroid. And it looks like a little cherry tomato. Don't do an excisional biopsy. That's their thyroid. The other thing is it might not stop. So it can go all the way into the superior mediastinum. So every time we were using our crystal doing our thyroid scans, the last thing we always did was just swing it over the mediastinum to make sure we didn't have an embryologic drift there. What else can you do here? The next thing to think about is this is going to give me my thyroglossal duct cyst. And that's going to move. It's a midline cyst that's going to move when you swallow. So that's a pretty common thing there. The last thing I want you to look at is I want you to name these bones. So what is this bone, and this bone, because hashtag make me care. Okay, so what are the three bones from superior to inferior?
Hyoid.
Okay, nice. I would take the thyroid too, because we're all pretty confident on that.
I meant
Okay.
hyoid, sorry.
Hyoid, thyroid,
Cricoid?
cricoid. Okay, hashtag make me care. When you talk about the hyoid bone is really important in forensic pathology, which was my hobby for many years. When you strangle someone, they don't like it, and so they struggle, which means your hands go up and then lock under the jaw, and then you squeeze the life out of them. But if you're an adult, you've ossified your hyoid bone, and so you get a hyoid fracture in strangulation. So the first thing you do in any autopsy of unknown cause is you very carefully dissect out the hyoid, because if it's fractured, murder, she wrote. So every pathologist dearly loves the hyoid bone. The cricoid bone we care about because of this right here. This is going to be your thyroid cricoid ligament. And anytime you have to do an emergency trach, that's what you're going to do. So I did this totally cool inner city internship where we got to stick needles in every place that they've ever stuck needles. And so, you sort of get the swagger of the intern. And I used to carry with me a silver 14 gauge needle on my key ring, because 14 gauge is a pretty big, that's a pretty freaking big needle. It's big enough that you can keep someone alive breathing. So anyone that's going to get angioedema from a bee sting and that, I would carry it with me, because I was going to take that needle and I was going to put it straight through that thyroid cricoid ligament, and you can sustain life because it's below the vocal cords. The other thing that you can do with that needle is you can do a tension pneumothorax. So when you talk about when you're training kids for battlefield medicine, the three things you can always do right now is volume for shock, needle for tension pneumo, and then thyroid cricoid ligament for laryngeal obstruction, which can be edema or fracture or lots of things. Okay? That's a pretty good diagram, hey? When we come up and say, okay, so those thyroid, non-thyroid, tell me what's my non-thyroid going to be? Because there's a little lesson there we've got to talk about. When I say non-thyroid, so it does not move on the swallow test, what's it going to be?
Nodules.
Yeah, what are the nodules going to be?
Lymph nodules.
Absolutely, okay? So we got to talk about, if you haven't learned this, it's just one of these really ways to get your brain right into prevalences. It's called the rule of 80s. And it's applied to anyone over age 50 years. Age, gender, time frame. When you have a non-movable mass in someone over age 50, 80% are lymph node. Of those lymph nodes, are you ready for this? 80% are malignant. Wow. And of those malignancies, 80% are squamous cell carcinomas. Okay, where are the squamous cell carcinomas coming from, Elisa? Where are they coming from? All I want you to tell me is this.
Sorry, I'm kind of freezing up a little. I didn't quite hear that.
That's perfectly fair. You've got me with a lymph node in the neck, and you're saying to yourself, this is not going to be good because he's old. And you stick a needle in it, which you will, and the report comes back, squamous cell carcinoma.
Yeah.
Where are you going to go look? This way or this way?
I think up.
Nice. That's exactly right, right? So when we say, where are we looking? Head and neck, right? Okay. That's kind of shocking, right? Because it's going to be a smoker. So your bias is always going to be to lung. But when I say squamous cell carcinoma of the head and neck, now all of a sudden you've got to differentiate into two different patient groups. This is a boomer next gen division. Why do I need to say that? So this is going to be over 70. This is going to be less than 65. Just as a way of thinking. What's the difference? Right? If it's an old guy, you're betting smoking, drinking. But what if it was a 54-year-old? What would you think then? Watch this.
Oh, yeah.
You've got to my generation can't deal with this, by the way. It's just because for us, everybody was a smoker and a drinker. So when I say to you, is the chance of cancer proportional to your exposure to the carcinogen? Yes. So if you're a smoker and a drinker, where's the maximum exposure? Side of the tongue, floor of the mouth. So the reason it's such a problem for my generation is when you say squamous cell carcinoma of the head and neck, I always think about taking my gauze and grabbing the tongue and just looking. It was as easy as pie. You couldn't miss it. There was an ulcerated white mass there. Yeah. Where does HPV infect?
Squamous epithelium.
Look at it's a different organ system, isn't it? I didn't say mouth, I said oropharynx. And you know where the commonest place in the oropharynx is? 50% of them are tonsil. Well, that's really hard to look at. You think it's easy to look? Yeah, you go try it with your next patient and tell me how confident you feel you got a really good look at the tonsils. It's not easy. So that's a problem for your generation, which is you've got to reorder your brain when you see someone coming in with these metastatic cancers. You've got to modify your brain to say, kind of got to look at the history here. Okay? So number one is going to be lymph nodes. Let's just finish this out here. Okay, so one is lymph nodes. What the heck happened here? Oh, went to the wrong place. Was in the next case. There we go. Okay. So one is lymph nodes. Two is going to be a thyroglossal, is going to be a branchial cleft cyst. Okay, tell me about them.
They're
They're usually off a midline.
Yes, they're off midline. They're cystic, and they arise from the...
Is it like the cervical sinuses or?
Oh, okay. I'm going to not abbreviate this then. They arise off the branchial arches. So when you take a look at your growing embryo, so if you're going to do your embryo, there's my chest going into my tail, there's my little eye. The head and neck form off the brachial arches. So when you come down on here, 2, 3, that tends to be my brachial cleft cyst. But when you come down here, This is where you start thinking about our 22q11ds syndrome, because this is where you get your abnormal migration of the parathyroids, of our aortic arch. So there's my tetralogy of Fallot, right? And then the last one's going to be my thymus. So you kind of break your brachial clefts into the two halves. So you think of your brachial cleft cyst, which is more the upper part of the head and neck. The big one for us is brachial cleft. When you get down to the higher numbers, like the 4s and 5s, now you're talking about the 22q11ds syndromes. Okay? Okay, so here's my nice little cyst sitting underneath the skin. If you stuck a needle in it, which you will, every mass, you stick a needle into it and give it a suck, what are you going to see in your fine needle aspirate? What would you expect the report to be if it's a brachial cleft cyst? Right? Because here's what we got here. There's my FNA for your lymph node. Fantastic. So you're going to stick a needle in all these guys, right?
Fluid?
Yeah, that's right. And what's the report going to be? You ready for this? This must be one of the commonest reports I ever sent out in my life. So amorphous means I can see sort of shadowy bits of crap around. And so the term we use for that is amorphous debris. The important thing is I don't see cells, right? So your commonest negative test will be amorphous debris, meaning I don't see anything. Did you think you had a cyst? So if you've got a cyst on ultrasound, that's the report you're going to be expecting. Okay? So we did our thyroglossal duct, our lymph node, and our brachial cleft. So that's actually a really important diagram. You do a lot of diseases off the head and neck. So you can think about the tongue, and if you hadn't thought about your brachial clefts, well, that's a pretty nice thing to add into that.